the discussion. So yesterday we did talk about the three different types of anemias. We had a discussion about the microcytic hypochromic anemia. We had a discussion about the macrocytic megaloblastic anemia. And we talked about a special example of a condition which is given the name of sideroblastic anemia, in which the patients were having the presence of microcytic hypochromic anemia. They were having basophilic stippling. They were having the presence of plumbism, especially in case of lead poisoning. Right? Hi, good evening, everyone. आज का पीडीएफ कोई स्पेशल नहीं है, कल वाला पीडीएफ ही कंटिन्यू करेंगे हम। जो हमारा कल वाला था उसी को हम डिस्कशन कंटिन्यू कर सकते हैं। तो हेमेटोलॉजी का डिस्कशन कर रहे हैं एंड उसी पीडीएफ के आगे नेक्स्ट पेज आप देखोगे, सो दैट इज व्हाट इज गोइंग टू बी हैविंग द प्रेजेंस ऑफ hemolytic anemia, right? Before I talk about hemolytic anemia, I do hope most of you can answer those questions quite comfortably, that ये वाले concepts है जो हमने डिस्कस भी किए थे, if you remember. Then we had a discussion about the fact that 2024's question, a patient who has undergone gastric surgery is more likely to be having a requirement for, answer that you have to understand over here is B12. Similarly, a second question tha, patient who is having B12 deficiency is going to be having which of the following as a manifestation. So neurological symptoms are present in the patient. They can be having hypersegmented neutrophil. They can be having the presence of Romberg sign positive. What is Romberg sign, by the way? Romberg sign is positive in them. No, Romberg sign is not going to be because of knuckle pigmentation. Yeah, so patient is going to be having a cerebellar dysfunction. He is not able to move properly, right? And if the B12 deficiency is going to be caused because of pernicious anemia, you have hyperpigmentation of the knuckles that is going to be seen in the patients, right? That is what we talked about. Now, talking about the condition in which the patients are going to be having excessive RBC destruction. Whenever there is going to be an RBC destruction, this is what is going to be associated with the development of anemia. Patients are going to be having jaundice. Patients are going to be having jaundice. Increase in tyrosinase activity because of B12 deficiency responsible for more production of melanin, causing pigmentation. RBC destruction is going to be responsible for causing development of anemia. There is going to be development of jaundice. There is going to be the presence of reticulocytosis. The retic count is going to increase. But what you need to remember is that patients are going to be having a decrease in the concentration of haptoglobin. Haptoglobin. Please remember from basic physiology, hemoglobin inside your RBC is your friend. Hemoglobin outside your RBC is your enemy. Right? Hemoglobin inside RBC is your friend. Hemoglobin outside RBC is your enemy, because this hemoglobin, when it is going to be present outside the RBC, can be responsible for causing nephrotoxicity. So we want to capture this hemoglobin. Whenever there is going to be an RBC destruction, because of which hemoglobin is going to be released, we capture this hemoglobin with the help of plasma proteins responsible for the formation of hemoglobin haptoglobin complex. So free haptoglobin concentration is always going to decrease whenever there is hemolytic anemia. Free haptoglobin concentration is always going to decrease whenever we're going to be talking about hemolytic anemia. Right? So even this was asked you as an exam question. Any other example of a plasma protein which is going to be protective apart from haptoglobin? दूसरा example आपको याद रखना है, hemopexin. Haptoglobin, hemopexin are examples of plasma proteins which are going to bind with hemoglobin, and they are going to be responsible for reducing the concentration of free hemoglobin, right? So patients के अंदर toxicity के chances कम हो जाएंगे. I hope ये वाली चीज clear है. अब next चीज आपको क्या समझनी है? Whenever we are going to be talking about RBC destruction can take place within the blood vessels. If that takes place within the blood vessels, that is given the name of intravascular hemolytic anemia. Intravascular, inside blood vessels. If that takes place in the spleen or the liver, that is called as extravascular hemolytic anemia. Now, how will you decide that in a question? Any patient who is going to be having anemia, having jaundice, having reticulocytosis, having decreased haptoglobin is going to be a case of hemolytic anemia. But when the question says extravascular hemolytic anemia के अंदर क्या होगा? Increase in the size of the liver, increase in the size of spleen. Increase in the size of liver, increase in the size of spleen. Hepatosplenomegaly will be seen because these organs have to work more. So extravascular के अंदर there is presence of extra size or increase in the size of liver and spleen. What is the hint that you get in a question that patient is having intravascular hemolytic anemia? Intravascular hemolytic anemia is characterized by RBCs destroyed inside the systemic circulation. So there is going to be hemoglobin urea. Hemoglobin urea. ठीक है. फ्री हेप्टोग्लोबिन की बात हो रही है डॉक्टर साहब. हेप्टोग्लोबिन क्यों इंक्रीज होगा भाई? कम हो जाएगा ना भाई. ये चीज नॉर्मल है, ये चीज नॉर्मली प्रेजेंट है. अगर ये हीमोग्लोबिन रिलीज होगा तो ये कॉम्प्लेक्स बढ़ जाएगा ना, फ्री हेप्टोग्लोबिन कम हो जाएगा ना. सो इंट्रावास्कुलर हेमोलिटिक एनीमिया इज गोइंग टू बी कैरेक्टराइज्ड बाय हीमोग्लोबिन यूरिया. And what is going to be the complaint of the patient? Patient is going to be having a complaint of altered color of urine. Altered color of urine. Right? So hemoglobin urea जब भी होगा intravascular hemolytic anemia, patients are going to be having altered color of urine. So when you have a jaundice anemia, hepatosplenomegaly, you think in terms of extravascular hemolytic anemia. Jaundice anemia, altered color of urine, you think in terms of intravascular hemolytic anemia. This is very, very useful for you to understand and crack certain questions in the exam. Now, what can be the causes of RBC destruction? RBC destruction can take place because of multiple reasons. Reason number one can be patient is going to be having inherited genetic defects. Inherited genetic defects can be seen because of problem at the level of membrane. And these conditions are going to be given the name of hereditary spherocytosis, very commonly asked in the exam, and hereditary elliptocytosis. Hereditary spherocytosis, hereditary elliptocytosis. Similarly, patients could be having presence of enzyme deficiencies. Enzyme deficiencies, very commonly asked in the exam, can be G6PD deficiency, G6PD deficiency, or the patients can be having the presence of pyruvate kinase deficiency. Then the patients can be having hemoglobinopathies. Hemoglobinopathy can be a problem of conditions like thalassemia and sickle cell anemia. Thalassemia, sickle cell anemia. But whenever we are talking about all these conditions, they are examples of they are example of intracellular causes of hemolytic anemia. The problem is within the cell. सेल की प्रॉब्लम है. सेल के अंदर क्या होता है? मेम्ब्रेन होती है, एंजाइम होते हैं, हीमोग्लोबिन होता है. And there is one condition that you need to remember over here, which is going to be an acquired genetic defect. That acquired genetic defect condition, which was asked to you as a 2024 question as well, is given the name of paroxysmal nocturnal hemoglobin urea. Paroxysmal nocturnal hemoglobin urea. अभी बात करेंगे सबके बारे में यार, फिर एक एक करके डिस्कशन करेंगे. When we are talking about the other conditions, the problem is outside the RBC. Extracellular cause of hemolytic anemia. So whether it is trauma, whether it is antibodies, whether it is infections, toxins, sequestration, they are examples of extracellular causes of hemolytic anemia. A common question जो एग्जाम में आपसे पूछा जाता है बार बार वो आता है इसके ऊपर. Which is the only example of an intracellular acquired. Right? Nowadays, the questions are being asked in the exam on conditions like hemolytic uremic syndrome, and you are going to be asked questions in the exam on other conditions, for example, malaria and babesiosis as well. So we'll just have a look at these conditions. Membrane abnormalities पे क्वेश्चन आया था 2023-2024 के अंदर. राइट? आपने कुछ नहीं करना, आपने सिर्फ इतनी बेसिक चीज याद रखनी है कि आपने इन क्वेश्चंस को एग्जाम्पल्स को ध्यान रखना है. इन एग्जाम्पल्स को आपने ध्यान रखना है और कुछ नहीं करना. क्या स्टकअप हो गया भाई? ठीक है, एक एक करके कंडीशन देखते हैं, फिर पता चल जाएगा. फर्स्ट कंडीशन, hereditary spherocytosis. Hereditary spherocytosis. Hereditary spherocytosis is an example of a condition in which the patients are going to be classically children. It's a condition that is going to be seen in case of children, and the patients are going to be having hemolytic anemia. This condition is caused because of autosomal dominant mode of inheritance. What is the problem? The patients are going to be having a problem of autosomal dominant. There is an enchirene defect in the patients. Enchirene defect in the patients. When there is an enchirene defect in the patient, RBCs are going to become chubby. RBCs are going to become spherical. RBCs are going to become spherical. Now, normal RBCs, as we discussed yesterday also. Normal RBCs are having this kind of an appearance. Central one-third pale area. Central one-third pale area. But in case of hereditary spherocytosis, will you have any central one-third pale area? The answer is no. 2022's question, a child is going to be having the presence of, a child is going to be having a presence of hemolytic anemia, because of which shape of the RBCs becomes spherical. So that is why it is called as hereditary spherocytosis. It is a genetic condition, autosomal dominant, and current defect is seen in the patients. RBCs are going to be having a spherical shape. No, it is not very common. It is not very common, doc. Why is the problem with the spherical RBCs? These spherical RBCs are going to get trapped in the spleen. So spleen is going to be destroying these chubby RBCs. In the spleen, the chubby RBCs are going to get destroyed. Right? So the size of the spleen is going to increase. That's why the patients are going to be having jaundice, anemia, and splenomegaly. Jaundice and anemia itself means hemolytic anemia. RBCs are being destroyed in the spleen, so spleen size is going to increase. Right? Whenever we are talking about peripheral smear is going to be showing you spherocytes. Peripheral smear is going to be showing you spherocytes. Instead of writing spherocytes, this is what is going to be given to you as a point in the exam. What is the typical feature of these RBCs? You do not have any central pallor in the RBCs. You do not have any central pallor in the RBCs. Right? Now, if the RBCs are being destroyed inside the spleen, is it going to be an example of intravascular or extravascular hemolytic anemia? It is an example of a cause of extravascular hemolytic anemia. So I will say in one line, आपने क्या चीज याद रखनी है? Hereditary spherocytosis is a pediatric hemolytic anemia. It is characterized by jaundice anemia, splenomegaly, and it is a cause of extravascular hemolytic anemia. Right? When RBCs are going to become spherical, then they become very fragile. RBCs are going to become very fragile. So if I perform a test which is given the name of osmotic fragility test, osmotic fragility is going to increase in the RBCs. RBCs become fragile, and osmotic fragility is going to be increased in the RBCs. So RBCs are going to be having an increase in the osmotic fragility. But please remember, osmotic fragility is a non-specific test. So what was asked to you as a question in the exam? The investigation of choice for these patients is flow cytometry. 2022's question, flow cytometry हम किसके साथ करते हैं? We use a dye which is given the name of eosin 5 meliamide. Eosin 5 meliamide. Screening test is osmotic fragility and investigation of choice is flow cytometry. बिल्कुल ठीक दिया हुआ डॉक्टर एस्ट्रल, क्योंकि रिवीजन नोट्स के अंदर ठीक दिया हुआ है, वही बोल रहा हूँ, ध्यान से सुनो. इन्वेस्टिगेशन ऑफ चॉइस इज फ्लो साइटोमेट्री, स्क्रीनिंग टेस्ट इज ऑस्मोटिक फ्रेजिलिटी. प्लीज ऑल्सो रिमेंबर अनदर फैक्ट. मान लीजिए ये इमेज दी गई आपको एग्जाम के अंदर, यू आर आस्क्ड टू आइडेंटिफाई द सेल ओवर हियर. द सेल ओवर हियर इज गोइंग टू बी स्फीरोसाइट. Why? Because there is going to be absence of central pallor. There is going to be absence of central pallor. Right? Whenever we are talking about spherocytes, it can be caused because of two common causes. One can be a condition that is called as autoimmune hemolytic anemia. Second can be a condition, hereditary spherocytosis. Autoimmune hemolytic anemia. Second can be a condition, hereditary spherocytosis. Autoimmune hemolytic anemia is more common. Autoimmune hemolytic anemia is more common. It is seen classically in case of adults. Hereditary spherocytosis is going to be seen in case of children. So age is one important differentiating factor. Second fact, in case of autoimmune hemolytic anemia, autoantibodies are present. Autoantibodies are absent in case of hereditary spherocytosis. Autoantibodies are absent in case of hereditary spherocytosis. Can we detect autoantibodies? The answer is yes. We perform a test which is given the name of Coombs test. So Coombs test is positive in case of autoimmune hemolytic anemia. Coombs test is negative in case of hereditary spherocytosis. So whenever you are asked a question in the exam about the presence of spherical RBCs, please remember autoimmune hemolytic anemia is a much more important cause of spherocytosis in comparison to hereditary spherocytosis. दोनों ही ज्यादा कॉमन होंगे, दोनों पॉजिटिव होते हैं इसमें, राइट? दोनों हो सकते हैं भाई, ऐसा जरूरी नहीं है कि इनडायरेक्ट ही होगा, दोनों हो सकते हैं, बोथ डायरेक्ट भी हो सकते हैं, इनडायरेक्ट भी हो सकते हैं. So this is a basic fact that you need to have an idea. Can I treat a patient having this condition? I can treat the patient having hereditary spherocytosis. There is no drug available. But can I do something to improve anemia? The answer is yes. How can I improve anemia? By removing the spleen. And you have a microbiology correlation. Whenever you are talking about spleen, spleen is an example of an organ which is very important filter for bacteria. So if I remove the spleen of the patient is at high risk of development of infections. So before doing the surgery of the patient, you must always vaccinate this individual. Hib vaccine, pneumococcal vaccine, capsulated organisms wali vaccine should be given to the patient. Hib vaccine, H influenza vaccine, and streptococcal and pneumococcal infection, strep pneumoniae ke liye pneumococcal vaccine has to be given to the patient. Right? Once you remove the spleen of the patient, anemia of the patient is definitely going to improve. What is the long-term complication of hereditary spherocytosis? Long-term complication of hereditary spherocytosis is that these patients are at high risk of development of gallstones. These patients are at high risk of development of gallstones. So that is what we need to remember about this kind of a condition. That is about hereditary spherocytosis. So they asked you 3 questions in the last 3 years in the exam. What was a child who was having the presence of anemia? He was having the presence of spherical RBCs. What is the next best investigation to confirm the diagnosis? Flow cytometry. The next question asked in the exam was a patient who was having the presence of a 10-year-old child who was having a hemoglobin value of 8 or 9, and he was having the presence of jaundice as well. He was having splenomegaly as well. And the question was having these episodes right from birth. What is the likely diagnosis? It is hereditary spherocytosis. 2023 का question था वो नीट का, right? So that is what we just need to have an idea over here. Splenectomy is not going to correct the defect in enkyrin. Splenectomy में आपने जो troublesome चीज थी उसको निकाल दिया, जो चीज पेशेंट के अंदर डिस्ट्रक्शन करा रही थी आपने उसको ठीक करा दिया. So that is what you need to remember over here. ठीक है? So the destruction is going to be less. Site of destruction is going to be less, and that's why the patient is going to be getting better. Next condition about which you need to have an idea is a condition that is given the name of hereditary elliptocytosis. Hereditary elliptocytosis is going to be characterized by the fact that patients are going to be having a problem at the level of spectrin. So RBCs automatically are going to be having an elliptical shape. They are going to be having an elliptical shape. ठीक है? That's what we are doing. नहीं, stones का reason infection नहीं होता. Stones का reason होता है that there is a increase in unconjugated bilirubin. Increase in unconjugated bilirubin is going to combine with calcium. So that is going to be responsible for the formation of calcium bilirubinate. And this calcium bilirubinate is going to get accumulated in the gallbladder. So that causes gallstones. Right? Surgery के अंदर जिसको आप पढ़ते हो, pigment stones, pigment gallstones. You read about cholesterol gallstones, you read about pigment gallstones, you read about mixed stones. So pigment gallstones are going to be seen in case of hemolytic anemia. Pigment gallstones are going to be seen in case of hemolytic anemia. Right? This is what we need to remember. Right? Another way of asking a question in the exam is with respect to the parameters. MCV, MCH, MCC. This is an example of a condition in which you are going to be having an increase in MCHC. MCH is going to be less, MCV is going to be less. MCHC is going to increase. Cells are becoming spherical, so therefore they are going to be having this kind of a situation. Right? So this is about hereditary spherocytosis, diagnosed with the help of flow cytometry. Next condition is what we need to remember over here, a condition which is caused because of an enzyme defect. This enzyme is given the name of glucose 6-phosphate dehydrogenase. Glucose 6-phosphate dehydrogenase. Try to follow what I'm trying to talk about over here. This is the enzyme glucose 6-phosphate dehydrogenase. Spherical हो गया ना आरबीसी because of loss of membrane. Loss of membrane के साथ साथ में थोड़ा सा loss of fluid हो जाता है. MCH means average hemoglobin in the cell. MCH means mean cell hemoglobin, average hemoglobin in the cell. MCHC means mean hemoglobin concentration. अरे यार ये तो फिजियोलॉजी था, फिर भी समझ लो. MCHC क्या होता है? MCHC is MCH divided by MCV. So in case of a person who's going to be having hereditary spherocytosis, hemoglobin is going to be less. MCV is going to be slightly greaterly reduced. So overall, the value of MCHC is going to be higher. MCHC value is going to be coming higher. अभी याद रहेगा, हीमोग्लोबिन भी कम हो गया, वॉल्यूम भी कम हो गया, बट वॉल्यूम इज अफेक्टेड मोर. दोनों कम हो गए बट वॉल्यूम और भी कम हो गया, तो ओवरऑल जो कंसंट्रेशन है वो ज्यादा हो गई. ओवरऑल कंसंट्रेशन जो है वो ज्यादा हो गई. That is why these RBCs are going to be having an appearance. जो dark सी appearance आपको देखने को मिली थी. Now coming back to our discussion, G6PD is an enzyme which is going to be responsible for the formation of a very important substance, that is NADPH. Why is NADPH important? Because NADPH is being utilized by an enzyme that is given the name of glutathione reductase. And this glutathione reductase is going to be responsible for the formation of reduced glutathione. So G6PD gives me NADPH. NADPH gives me reduced glutathione. And the purpose of reduced glutathione is it is going to be responsible for protection against free radicals. Free radicals or oxidative stress. Free radicals or oxidative stress. So normally in the metabolism, also cells are going to be having the removal of the free radicals or the reduction of the oxidative stress because of molecules like glutathione peroxidase. Right? Now, whenever we are going to be talking about a situation in which a person is going to be having G6PD deficiency, then that means NADPH will be less. That means reduced glutathione will be less. And what will happen to the chances of damage by oxidative stress? The chances of damage by oxidative stress is going to be higher. What you just now understood was a INI-CET question 2022. G6PD deficiency is going to be characterized by reduced formation of the NADPH, reduced formation of reduced glutathione, high chances of damage caused by free radicals. So whenever we are going to be talking about G6PD deficiency, this is a line that is mentioned in your notes as well. Now, if I talk about the inheritance of this condition, this is an example of an X-linked recessive condition. So X-linked recessive conditions loves boys. It's more commonly going to be seen in case of males in comparison to females. What is going to be associated with? चलो लड़कों को ये लगा कोई तो प्यार करता है हमें. When we are talking about the causes of G6PD deficiency, the causes can be multiple. One can be fava beans, which is going to be an example of food material. The second can be, this can be associated because of infections. So pay attention to a question which is going to be talking about infections like pneumonia, endocarditis, septicemia, urinary tract infection, right? And whenever we are going to be talking about drugs, even they can cause free radical formation. इसमें important दवाई जो बार बार आपसे एग्जाम में पूछते हैं, that is a drug like primaquine. You have other drugs also, ATT, rasburicase, sulfonamide, so many of them, but primaquine is a classical example. So in the earlier days, and if you are having the availability of facilities, in some of the countries, in some of the hospitals, you actually do the testing for G6PD deficiency before giving primaquine. Primaquine का इंपॉर्टेंस तो पता ही आपको फार्माकोलॉजी के अंदर, मलेरिया के अंदर क्यों होता है. It's the only example of a drug that is not going to be acting on the RBCs. It is an example of a drug having extra erythrocytic action. So it is required for radical cure. It is required for radical cure. Extra erythrocytic action होता है ना. So this is going to be importantly given. अगर आपको मलेरिया का relapse नहीं चाहिए, recurrence recrudescence नहीं चाहिए, so primaquine has to be given. So primaquine can be given only safely when you have a patient who is going to be having normal G6PD levels. Now imagine a condition in which the patient is going to be given this kind of a drug. So what is going to be happening over here is, if there is going to be a history of any of this sort, then that means there is increase in the oxidative stress. This is going to result in the oxidation of hemoglobin. Hemoglobin in a normal person is going to be soluble. But once hemoglobin is going to be having oxidation, it becomes insoluble. So then that is going to be responsible for the formation of Heinz body. It is going to be responsible for the formation of Heinz body. When such RBC is going to be passing through the spleen, ये RBC है हमारा, इसके अंदर you are going to be having the presence of Heinz body. When this RBC is going to be passing through the spleen, then this RBC is going to be having an appearance like this. It will feel to you as if the RBC has been bitten off. Appearance होती है. Actually, reorganization of cytoplasm takes place. RBC is going to be having an appearance that it has been bitten by the splenic macrophage. So this is what is going to be given the name of a bite cell. Sometimes the oxidative stress is very, very high. When the oxidative stress is very, very high, the patients can be having physical damage to the RBC. So that can be responsible for development of intravascular hemolytic anemia. Now, don't look at your notes, try to remember and revise. What is going to be the clinical features of intravascular hemolytic anemia? किसी भी hemolytic anemia के अंदर जो clinical manifestations होंगी वो रिवाइज कर लीजिएगा एक बारी. So patients will be having the presence of jaundice and anemia. And patients will be having the presence of altered color of urine. So I will tell you the exact history which has been given in the exams earlier. A boy has been going to a camp. In the camp, he had some kind of an infection, or they were going to a place where malaria was prevalent. So they were given a drug like primaquine by the teacher. Right? After 48 hours of taking the drug, the boy had a decrease in his energy levels. He had a fatigue and he had a passage of altered color of urine. His peripheral smear showed you presence of cells having this kind of an appearance. So what is the likely diagnosis in this boy? G6PD deficiency. So G6PD deficiency is an example of a condition which is a classical example of both intravascular as well as extravascular hemolytic anemia. Intravascular क्यों हो रहा है? Because of physical damage to the RBC. Extravascular क्यों हो रहा है? Because ये bite cell है. अगर ये डैमेज ज्यादा हो जाएगा तो स्प्लीन के अंदर डिस्ट्रक्शन हो जाएगा, और अगर स्प्लीन के अंदर डिस्ट्रक्शन हो जाएगा तो दिस इज गोइंग टू बी अ कॉज ऑफ एक्स्ट्रावैस्कुलर हेमोलाइटिक एनीमिया. Extravascular hemolytic anemia. Right? So these are exam questions. So mode of inheritance of G6PD deficiency has been asked in the exam. X-linked recessive. What's the problem? The flowchart is important. This was I&I question. Remember the fact, what is going to be responsible for the trouble of the patient? Intake of fava beans, infections, or drugs like primaquine, ATT, sulfonamide, and splenomegaly, yes. And the patients are going to be having peripheral smear finding, which is going to be associated with the term bite cell, also called as degma site. Bite cell. Degma site. डॉगी ने काट लिया, डॉगी ने बाइट कर लिया, डेग्मा साइट. ये डॉग नहीं है एक्चुअली, ये स्प्लेनिक मैक्रोफेज है. हाइंस बॉडी, which is an example of the insoluble form of hemoglobin, that can be seen over here. Oxidized hemoglobin, which is going to be getting deposited in the RBC. So what is Heinz body? Heinz body, HB. Heinz body is hemoglobin, but कौन सा hemoglobin? Oxidized hemoglobin. Not has been asked in the exam, but you need to remember for advanced questions, some of the patients can be having cells which are having a stretched membrane. RBC sometimes can be having stretched membrane. Say, for example, if this is the RBC, which is normal, in case of G6PD deficiency, RBCs can be having a stretched membrane, as if the RBCs has developed a blister. So that is what is going to be given the name of blister cell. ये special staining है भाई, special staining. ये routine staining, routine appearance, ये special staining. Right? So that is what you need to remember. Oxidize को देखने के लिए आपको करना पड़ेगा ना. That's what you need to remember. So blister cell. So this is what is going to be required. Now, when we are talking about G6PD deficiency, please remember G6PD deficiency is selectively going to target older RBCs. It targets older RBCs. Fresh cells are not affected by it. Fresh cells are not affected by it. So imagine what is going to happen. मान लो 100 cells हैं. 100 cells हैं. 100 cells में से मान लीजिए 80 cells are going to be of middle age, 10 are old, 10 are young. So these 10 cells which are old are going to die first. They will die first. And they will be replaced by fresh cells. New fresh cells are going to join from the bone marrow. तो अभी मिडल एज सेल्स हो गए और सारे फ्रेश सेल्स हो गए. देयर इज नो एल्डरली सेल ऑन सेकंड डे या थर्ड डे. सो व्हाट विल हैपन? द hemolysis is going to stop. So this is an example of a condition that your books make a mention, self-limiting. G6PD deficiency, the hemolytic anemia is self-limiting. अपने आप ही any patient का जो hemolytic anemia that is going to get better. So with respect to the risk factor, after 48 hours, patient is going to be having hemolysis and the patient is going to be getting better after 2 or 3 days. So you have to manage the patient only for these 2 or 3 days. Nothing else has to be done for the patient. Self-limiting condition. Self-limiting condition. Yeah, it is a cause of intermittent, short-term hemolytic anemia. Because it is not causing long-term hemolysis. Will gallstones develop in the patient? No. Gallstones will not develop. Gallstones के लिए hemolytic anemia होना चाहिए chronic. So these patients are not going to be having the chronic hemolytic anemia. So that is an example of a G6PD deficiency that you need to have an idea. Second example of an enzyme deficiency that you need to have an idea is pyruvate kinase deficiency. Pyruvate kinase deficiency. Pyruvate kinase deficiency is going to result in hemolytic anemia that is classically seen in case of newborn. Classically seen in case of newborn. यूरिन के अंदर क्या दिखेगा? यूरिन के अंदर है ऑल्टर्ड कलर ऑफ यूरिन. ऑल्टर्ड कलर ऑफ यूरिन. हीमोग्लोबिन यूरिया. ऑल्टर्ड कलर ऑफ यूरिन. ब्राउनिश यूरिन. Right? Hemolytic anemia. Newborn. When you see in pyruvate kinase deficiency, patients are going to be having a very characteristic feature. When you see their RBCs are going to be having a spike appearance like this. Regular spike appearance. So these cells are going to be present. They are going to be given the name of Burr cells. Burr cells. Burr cells, which are also going to be given the name of echinocytes. Burr cells or echinocytes. You had a question in the exam 2024 given on this as well. Acanthocyte, echinocyte. Concept आया था एग्जाम के अंदर. So pyruvate kinase deficiency is going to be responsible for causing echinocyte formation. Echinocyte formation. These are RBCs which are going to be having regular projections, equally spaced projections. A similar appearing cell is what can be seen over here. यहाँ पे projection है, यहाँ पे projection है, यहाँ पे projection है, यहाँ projection है, यहाँ projection है. Asymmetrical projections. When you're talking about asymmetrical projections, this kind of a cell is going to be given the name of acanthocyte. Acanthocyte. So acanthocyte is an example of a cell which you are rightly saying is also given the second important name of a spur cell. It's called as a spur cell. Acanthocyte. Right? This can be seen because of patients having liver disease, can be seen because of A beta lipoproteinemia, right? Yeah, that's a question asked in the exam. Now you recall. So in case of pyruvate kinase deficiency, because we are talking about enzyme deficiency, so I thought it is important. Enzyme deficiencies, you are going to be having echinocytes, and these are given the name of Burr cells. Right? So whenever you are going to be having the presence of, इसमें क्या कंफ्यूजन होना चाहिए यार? जब भी हम इसका नाम देखेंगे तो हमें याद रहेगा ना, इक्वली स्पेस्ड प्रोजेक्शंस. इफ यू आर हिंदी स्पीकिंग गाय, अगर बराबर बराबर प्रोजेक्शन दिखे, बराबर इक्वली स्पेस प्रोजेक्शन, सो दैट इज अ काइनोसाइट और बर्र सेल. और कहीं पे भी निकल रही है, एसिमेट्रिकल है, यहाँ पे डिस्टेंस पास में है, यहाँ पे डिस्टेंस दूर है, एसिमेट्रिकल है तो कैंथोसाइट. ठीक है. लीवर डिजीज, ए बीटा लाइपोप्रोटीनीमिया. liver disease, A beta lipoproteinemia. ठीक है, so hemolytic anemia in case of newborn. मेम्ब्रेन डिफेक्ट्स है ना, मेम्ब्रेन डिफेक्ट्स इन द लिपिड्स. पायरुवेट काइनेस काम नहीं करेगा तो मेम्ब्रेन प्रॉपर नहीं बन पाएगी. मेम्ब्रेन प्रॉपर नहीं बन पाएगी, so the membrane is going to be having projections like this. Right? So this is what we need to remember so far as G6PD deficiency is concerned. So it has an important link because it is going to be having your discussion of knowledge of infections. Like microbiology, it is going to be related with the pharmacology knowledge as well about these drugs. And therefore, what you need to remember over here is this kind of a condition. Pretty important, pretty easy questions asked in the exam from this. Right? So biochemistry or path ka knowledge hai iske andar, pharma or micro ka knowledge hai, that's why it becomes important. Next, we have a condition which has been asked in the exam so very easily. We are talking about an example of a hemoglobin problem. This condition is going to be given the name of sickle cell anemia. Sickle cell anemia is going to be seen because of a problem in the beta globin chain. 6th position में problem है. What's the problem? It's a problem of point mutation. It's a problem of point mutation. What kind of point mutation is? Glutamic acid is going to get replaced by valine. Glutamic acid is going to get replaced by valine. So if I talk about physiology, normal hemoglobin is HbA. It is made up of 2 chains of alpha, 2 chains of beta. कैसे याद रखते हैं, हमें पता ही है निमोनिक. This is the good guy. Glutamic acid is good. It is going to go. Glutamic acid, good guy goes. कलयुग चल रहा है. Villain is going to be welcome. Villain is going to be welcome. So glutamic acid goes. Villain is welcome. Right. So because of this, the beta chain is going to be defective. So जो hemoglobin बनेगा patients के अंदर, that is HbS. That is alpha 2, beta 2, and you are going to be writing S over here. You're going to be writing S over here. So whenever glutamic acid is being replaced by valine, you're going to be having S over here. That is sickled hemoglobin. Sickled hemoglobin. HbS. Sickle cell anemia ka hemoglobin. The problem with this kind of hemoglobin is that there is going to be a decrease in its solubility. This is going to be having a problem in its solubility. So whenever this hemoglobin is going to be seen inside the RBC, the RBCs are going to be having hemoglobin polymer formation. Hemoglobin polymer formation. To accommodate this RBC, solubility is going to be less, polymer formation takes place. To accommodate this hemoglobin, RBCs have to take a shape like this. Polymer बन जाते हैं, polymers of hemoglobin. To accommodate the polymers, RBC has to change its shape. It is going to become sickle shape. Chances of polymer formation increase at the time of dehydration and at the time of hypoxemia. Chances of polymer formation increases at the time of dehydration and at the time of hypoxemia. So this is an example of a condition talking about the genetics. It is an autosomal recessive condition seen more commonly in case of African children. And this child is going to be having the presence of sickled RBCs. Now, what is the problem with the sickled RBCs? The sickled RBCs are very sticky. They are responsible for clogging the microvessels. So there is a smaller vessel occlusion. Vaso-occlusion is going to be seen. Because of vaso-occlusion, trouble number 1. Very common complaint given in the exam questions. Patients are having the presence of non-healing skin ulcers on the legs. Non-healing skin ulcers on the legs. So non-healing lower limb ulcer around the medial malleolus is what is going to be seen in the child. Right? आपको मेरे को पता भी नहीं चलता कि हम बिना चप्पल पहने जा रहे हैं. We are not having any footwear, let us say, and we are going to be walking around and there can be multiple scratches, fine scratches, but that doesn't make a difference. Auto heal हो जाते हैं. Right? But in these individuals, there is going to be a non-healing ulcer present on the lower limb. Right? Another thing which can be seen in the patient can be, the patient can be having a complaint of abdominal pain. Vaso-occlusion can be causing involvement of the abdominal organs as well. They can be having abdominal pain. A third important complaint of the patient can be, they can be having swelling of their hands and feet. That's called as hand-foot syndrome. Hand-foot syndrome. Small digits of the hands and feet are going to get swollen. Hand-foot syndrome. So there is inflammation of the small bones. It is called by the name of hand-foot syndrome. The reason for the hand-foot syndrome is dactylitis. Dactylitis. So hand-foot syndrome is what is going to be seen in the patients over here, right? And what is going to be important over here in the patient is going to be the fact that these patients could be having the presence of involvement of other organs as well. For example, spleen can be affected in these organ patients. Spleen can be affected. Now, when we talk about involvement of the spleen, it is interesting to note that there is abnormal shape of the RBCs. So RBCs are going to get trapped in the spleen, therefore resulting in congestive splenomegaly. Size of the spleen is initially going to increase. But after many years, there is going to be a gradual ischemic damage to the spleen. Gradual ischemic damage mein kya hoga? The tissue is going to get replaced by fibrous tissue. So initially the spleen is going to be having increase in the size, congestive splenomegaly. And after many years, 10 साल के बाद, 12 साल के बाद क्या हो जाएगा? The spleen is going to get replaced by fibrous tissue, decrease in the size of the spleen. When you are having congestive splenomegaly, there is a microscopic finding over here. It is given the name of Gandy-Gamna body. Gandy-Gamna body. There is presence of congestion in the spleen because of which calcium gets deposited. And when calcium gets deposited, it is going to be given the name of the Gandy-Gamna body. When there is a decrease in the size of the spleen, we say that there is going to be a term that is being used over here, autosplenectomy. Autosplenectomy. So all these are important terms that you just need to keep in your mind for the purpose of correcting a question in the exam. So a child having African descent comes to you because he's having the presence of non-healing ulcer in the lower limb and he's having the presence of abnormal shape of the RBCs. Sickle cell anemia is a likely differential. Child is going to be having African descent. He's having the presence of severe swelling in the hand and feet, hand-foot syndrome. So that is going to be again a patient who's likely to be having sickle cell anemia. Patient is having presence of abnormal shaped RBCs, which are going to be seen because of the presence of hypoxia and dehydration, sickle cell anemia. Patient is going to be having the presence of something like acute chest pain, acute abdominal pain, acute chest syndrome. Involvement of pulmonary vessels can be seen in the patient. Now, this is an emergency, and the concept is simple. If you have involvement of the pulmonary vessels, that can be responsible for causing decrease in the oxygen concentration. जितना oxygen concentration कम हो जाएगा, the chances of sickling is going to increase. So pulmonary infections and pulmonary problem in the patient has to be given top priority. Acute chest syndrome is an emergency because otherwise the patient is going to be having worsening of his symptoms in a short span of time. So even as a MBBS doctor, if you know a patient has sickle cell anemia, the basic thing that you can do for the patient is always take care of these two things, hypoxia and dehydration. Fluid लगा दो मरीज को, IV fluid दे दो फटाफट और patient को oxygen दे दो. You are going to be making the patient far better. Sometimes what can be seen in the patients can be having involvement of the bones, right? Acute chest syndrome precipitated by pneumonia. The patients can be having a development of avascular necrosis. Avascular necrosis is what is going to be affecting the femur. Avascular necrosis is what is going to be affecting the femur. Or the patients are going to be having another important fact. The patients are going to be having the development of a X-ray appearance that is given the name of crew cut appearance. X-ray appearance that is given the name of crew cut appearance. Hanji, polymerization is taking place in the deoxygenated state. So polymerization increases at the time of hypoxemia. Crew cut appearance. Some patients, especially male children, can be having an uncommon presentation in the form of development of priapism, unwanted erection of the penile tissue, painful erection of the penile tissue, right? So that is an emergency. So these are the important presentations that you must keep in mind. Sickling can also cause involvement of the renal blood vessels. So patient can have papillary necrosis also. So practically the concept is what you need to remember, that patients can be having an involvement of any type of a important or vital organ in the body, and that can be responsible for causing the trouble. Now, what can be the possible images which can be shown to you in the exam? So this is a classical image that you need to be able to pick up in the exam. This is an example of the sickled cell. This is an example of a sickled cell. Acute chest syndrome means severe pain in the chest, and the patient is having hypoxemia, right? So this is an example of a sickle cell. Now, whenever we're going to be talking about this kind of a condition, how exactly do we plan to make a diagnosis? First thing is the patients are usually going to be having the presence of high risk of infections. So there is increase in TLC. There is increase in the TLC. Second fact that you need to remember is that you can be performing screening test. Screening test can be done with the help of chemicals. And the example of chemicals which can be useful for the purpose of screening include dithionite test or metabisulfite test. Dithionite test or metabisulfite test. You take the blood sample of the patient, add this chemical, observe the blood specimen, the peripheral smear under microscope. You see, these chemicals are going to be responsible for sucking out oxygen. So what is going to be happening is once you add these chemicals to the blood sample and look at the peripheral smear, you are able to see the sickled RBCs. So these are examples of sickling, the screening test. Again, given to you as a question, 2023's exam, right? But this is not the investigation of choice. Investigation of choice for these patients happens to be gene sequencing. Gene sequencing. If gene sequencing has not been given as an option in the exam, of course, you can go in for the other investigation like hemoglobin HPLC. Hemoglobin HPLC. Not electrophoresis. Cumbersome and not preferred these days. Cumbersome, not preferred these days. एक्यूट चेस्ट सिंड्रोम में पेशेंट को निमोनिया हो रहा है, निमोनिया के कारण इन्फेक्शन हुई, इन्फेक्शन के कारण हाइपोक्सीमिया हो रहा है, पेशेंट इज गोइंग टू बी हैविंग क्लॉगिंग ऑफ द पल्मोनरी वेसल्स बाय सिकल्ड आरबीसीज. Severe pain in the chest and hypoxemia. Severe pain in the chest and hypoxemia. Acute chest syndrome. Severe pain in the chest, hypoxemia associated with infections. Right? Who made WB with soulless space? क्या मतलब? High performance liquid chromatography. ठीक है? That's what you need to remember. Now, what can be done for the treatment of this patient? What can be done for the treatment of this patient? Of course, the treatment of the patient can be done with the help of a basic thing. मैंने बनाई है भाई, मैंने बनाई है. I'll take the responsibility on behalf of the team. Because you have to note down only the keywords, not everything. Some concepts, some stories have to be kept in mind, right? When you're talking about the treatment, you have to give oxygen to the patient, you have to give fluids. Of course, at times you are going to be requiring painkillers as well because the patients are having severe pain. That's what you need to remember. One example of a drug that is being given to the patient has been asked in the exam. That drug is given the name of hydroxyurea. Hydroxyurea. We have a lot of them. बाकी भी याद कर ली. मोनोक्लोनल एंटीबॉडी याद हो गई. Excellent. That's what you need to remember. Cecal creasel, cecal creasel, cecal creasel. ठीक है? So these are the important things that you need to remember. At least remember this kind of an image. This image is very important. ये एग्जाम में नहीं आती जस्ट फॉर द सेक ऑफ अंडरस्टैंडिंग कि ये फाइब्रोटिक एरिया जो पेल पिंक दिख रहा है आपको. Calcium is being deposited over here, so that's given the name of the Gandy-Gabna body. Associated with then subsequently followed by the presence of autosplenectomy. Then you're going to be having a picture like this. This is going to be asked maybe as a biochem question, but this was an example of what is given the name of hemoglobin electrophoresis. Hemoglobin electrophoresis. So in case of a normal individual, this is what you're going to be expecting. You are going to be having the presence of one band like this, a thick solid band over here at HPA level, right? In case of an individual who's going to be having the sickle cell trait and the sickle cell disease. When do we say sickle cell disease? We use the term sickle cell disease when both the genes are affected. When both the chains are affected. Both chains are affected. Beta chain. Both are affected. And we use the term sickle cell trait when only one chain is affected. जीन सीक्वेंसिंग है नीचे क्या लिखा है एचपीएलसी एचपीएलसी ऑफ हीमोग्लोबिन वही तो दिखा रहा हूँ so this is what is going to be given the name of homozygous disease and this is what is going to be given the name of heterozygous. One gene is normal, another gene is defective. One gene normal, another gene defective. Which of them is going to be more severe for your patient? Which is going to be more severe for your patient? Which is going to be more severe for a patient? Of course, sickle cell disease is much more severe. Why is it more severe? Because it means that the patient is having. Why is homozygous disease more bad? Sickle cell disease is going to be bad for the patient because that means the patient is having predominantly HbS. सबसे important hemoglobin HbS होगा इस patient के अंदर. So it is going to be having a high chance of development of sickling episodes or vaso-occlusive crisis. Right? This is what we need to remember. Please remember the fact patients having sickle cell disease. Normally, I said you are having alpha chain and beta 2 chain. Normally, HbA के अंदर ये होता है. Patients who are going to be having sickle cell disease, they are having alpha 2 chain and beta 2 chain, but both of them are abnormal. So in patients having sickle cell disease, please remember this fact. Patients having sickle cell disease, there is no hemoglobin A. There is no hemoglobin A. These patients have only and only hemoglobin S. Sickle cell disease patients do not have hemoglobin A, they just have hemoglobin S. Then an interesting fact that we need to remember over here is about another hemoglobin C. Hemoglobin C is going to develop in case of an individual when there is a replacement of glutamic acid by lysine. At which position? It is going to be again associated with the presence of the beta 6 position. So beta 6 position, glutamic acid is going to be replaced by lysine. How do we remember it? When you say lysine, it is better you write it as lysine. Hemoglobin C. Hemoglobin C is going to be seen because of lysine. C. It is telling you. चिल्ला चिल्ला के बता रहा है आपको आंसर. Lysine. What is the importance of knowing about this kind of a lysine? For the simple fact that lysine is going to be responsible for having the presence of the formation of hemoglobin C inside RBCs. So this hemoglobin C is also going to be becoming insoluble. And now it is going to be responsible for the presence of C for, remember, crystals inside RBCs. Crystals inside RBCs. Lysine C, hemoglobin C is responsible for crystal formation inside RBCs. Crystal formation inside RBCs. Right? So that is what we need to remember. So this is about sickle cell anemia. So this investigation, please remember in biochemistry is what is going to be given the name of electrophoresis. Why we say electrophoresis? Because you are having the presence of an anode, you are having the presence of a cathode. Right? Old question if you want to remember. Anode A से start होता है, hemoglobin A जो normal होता है, anode के पास होता है. Hemoglobin S जो होता है पीछे रह जाता है, वो slow होता है. Slow होता है. Hemoglobin S जो होता है वो slow होता है. So A और F जो होते हैं वो इस तरफ होते हैं. A के पास होता है, anode के पास होता है A. F जो होता है फास्ट होता है. फीटल हीमोग्लोबिन वो फास्टली मूव करता है नोड के पास. डिजीज का नाम ही एचबीसी है भाई. एचबीसी डिजीज, एचबीसी ट्रेट ऐसे बोलते हैं इसको. और एस वाला जो होता है वो स्लो होता है, वो पीछे रह जाता है. हीमोग्लोबिन सी जो होता है वो कैथोड के पास होता है. ए वाला एनोड के पास, सी वाला कैथोड के पास. ये चीज आसान है. ए वाला एनोड के पास, सी वाला कैथोड के पास. A goes with anode, C goes towards cathode. F is fast, so it goes faster towards anode. Faster towards anode. Right? S is slow. Slow one is towards cathode. ऐसे याद रख लो. F and A are going to go towards anode. F and A go towards anode fast. ठीक है. हाँ ऐसे याद रख सकते हो. CSF वाला याद रखना कैसे भी यार. इट इज योर चॉइस. It is purely your call. How exactly do you wish to remember this? But less likely to be asked in the exam because we are not performing this test routinely. This is a second investigation that is what is given the name of HPLC. What is HPLC? High performance liquid chromatography. High performance liquid chromatography is going to be telling you about the quantity of hemoglobin, and it also gives you the amount of hemoglobin. Amount of hemoglobin and quantity of hemoglobin both can be determined over here. So based upon this kind of a graph, what is your patient having? Normal individual, sickle cell disease, normal patient, sickle cell disease or sickle cell trait. He is having HBS, no doubt, but he is also having HbA. I told you a few minutes back. In sickle cell disease, HbA is not there. So he is having both of them. So he is a case of sickle cell trait. He is a case of sickle cell trait. He is a case of sickle cell trait. Any patient who's going to be having enzyme deficiencies, any individual who is going to be having enzyme deficiencies, or any individual who's going to be having hemoglobin defects. Of course, they are having anemias, but do they have an advantage? The answer is yes. The advantage that we have in these patients is protection from malaria. Protection from malaria. So that is why these are going to be prevalent in certain geographical areas where malaria is present. The chances of such hemoglobinopathies or the chances of such enzyme deficiencies, of course, Africa, you all of you are aware, is an example of a malaria endemic zone. So you are going to be having high number of people who are going to be having such enzyme deficiencies or hemoglobin disorders, which are going to be present in these regions. Right? So falciparum malaria से protection रहता है in case of G6PD deficiency, in case of patients having sickle cell anemia, and in case of patients who are going to be suffering from a condition like thalassemia as well. ठीक, ये चीज हमें याद रखनी. So this is about the investigations. Not forgetting the fact, this is what is going to be important for the patient as well. Right? So screening test performance, that is what is going to be required. Then we talk about an example of a hemoglobin disorder, which is going to be given the name of thalassemia. Not the kind of thala that you want to have in your life. Thalassemia. So thalassemia, which is also being given the name of Mediterranean anemia. Hemoglobin is actually going to be becoming less in these patients. So it's a problem of quantity. Sickle cell anemia was a problem of quality. Hemoglobin hai to sahi, it is abnormal. There is hemoglobin, but that is abnormal. But thalassemia is an example of a condition in which the disease tell you there is less amount of hemia, less amount of hemoglobin. So thalassemia is a hemoglobin problem in which the quantity of hemoglobin gets affected. Now, whenever we are going to be talking about the hemoglobins, just a quick recap. These are the hemoglobins that we have in case of a normal adult. Alpha 2, beta 2, alpha 2, gamma 2, alpha 2, delta 2. Right? Whenever we're going to be talking about a patient who's going to be having thalassemia, there is a problem either with the alpha chain or there is a problem with beta chain. What can be the problem? Alpha thalassemia is going to be seen because of a patient who's going to be having a gene deletion. Beta thalassemia is going to be seen in patients because of a gene mutation. Gene mutation. गामा है भाई, गामा। अल्फा बीटा गामा, ये डेल्टा इधर। ठीक है। whenever we are talking about alpha chain, the beta chains and the alpha chains, how many alpha chains are there? Two. So this is what is known to you, chains, genes. If I'm looking at alpha chains, there are two chains. If I'm looking at beta chains, there are also two chains. But for the formation of alpha chains, how many genes are required? Four. For the formation of beta chains, how many genes are required? Two. बहुत ही बेसिक फैक्ट्स हैं, बट इसमें गलती हो जाती है लोगों से. Beta is two chains, and two chains are coming from two genes. Alpha is two chains, but two chains are coming from four genes. What is the chromosome present in them? That is what is usually known to a lot of people. Chromosome number 16, chromosome number 11. Chromosome number 16, chromosome number 11. Right? That's what you need to remember. So beta का तो सब कुछ आसान है ना. Beta is just like B ना. In case somebody ever has a doubt, beta is just like B. B का मतलब है second alphabet. And second alphabet का मतलब it's easy for you to understand ना. Two genes. Also remember 11. 1 plus 1 is 2. If you ever have a doubt. If you ever have a doubt. And as somebody rightly said, 16 is the time when you hit puberty. So that's when you start thinking that you have become an alpha male. Actually, you're not. डैडी के पैसे पे तो कोई भी कर सकता है. बट यू स्टार्ट थिंकिंग दैट यू आर एन अल्फा मेल. ठीक है. सो इधर वेज गुड, व्हाटएवर यू विश टू रिमेंबर. ठीक. ये चीज हमें ध्यान रखनी है. अब कमिंग बैक टू आवर डिस्कशन, व्हाट इज गोइंग टू बी द फंडामेंटल प्रॉब्लम इन अ पेशेंट. Whenever we are talking about thalassemia, please remember the fact that's known to a lot of you. Beta thalassemia is much more common. And one of the reasons for beta thalassemia is going to be, the commonest reason happens to be point mutations. Point mutations. नहीं, not exactly. You're not dependent upon your parents after doing MBBS at least. 50,000 रुपये तो कमा लोगे यार. That is good enough. अगर मैं 4500 इंटर्नशिप के स्टाइपेंड के अंदर राजा फील कर सकता हूँ, तो तुम 50,000 रुपये अभी कमा रहे हो, तब तो तुम सुपर किंग हो यार. एंड इट इज अ ट्रांजिएंट थिंग. Whenever we are going to be talking about thalassemia, this can be having three subtypes. If there is a problem with the beta chain, it's a temporary joblessness. Don't say it joblessness. You are waiting. You are waiting because you are going to be launched like a rocket. है ना. लॉन्च पैड पे खड़े हो अभी तो. सो whenever life is pulling you back, always remember that you are an arrow. एरो को आगे जाने के लिए थोड़ा सा पीछे जाना पड़ता है. अभी ये वो वाला फेज चल रहा है. तुम्हें लॉन्च करेंगे, चिंता मत करो. बहुत जल्दी लॉन्च करेंगे. बीटा थैलेसीमिया में थे तुमसे पहले बहुत सारे लोगों ने किया है. आपसे लास्ट बैच के अंदर जो बैच था उसके अंदर देवी हैड वंडरफुल पीपल. देयर वाज अ गाय हु वाज इन द इंडियन आर्मी. राइट. ही वाज अपीयरिंग इन द एग्जाम आफ्टर गैप ऑफ 6 years. एमबीबीएस करने के बाद ही वाज पोस्टेड टू डिफरेंट प्लेसेस, डिफरेंट टेरेन्स, एंड आफ्टर 6 years he appeared in the exams. नहीं नहीं, मैं वापस आ गया भाई, चिंता मत करो। मैं मोटिवेशन वाली बातें कर रहा था ना। तो उन्होंने कहा कि सर अभी रुक जाओ आप। ये भी एक मोटिवेशन है ना। आप कुछ अच्छा काम कर रहे हो तो बीच में कुछ ना कुछ ऑब्स्ट्रक्शंस आएंगी, तो लाइट फ्लक्चुएट कर गई। हम्म। है ना। तो देर हैव बीन पीपल बिफोर यू हैव बीन प्रिपेयरिंग फॉर द एग्जाम्स यार, तो पीपल हैव फेस्ड मोर हार्डशिप्स। तो इतनी रैंक से उन्होंने इतनी रैंक कर दी अपनी। क्योंकि उन्होंने बोला सर, ऐसा बताया गया था ना कि जीरो की तो वैल्यू होती नहीं, तो ये जीरो काट दिया, ये जीरो काट दिया, ये जीरो काट दिया, इतनी रैंक देंगे। ऑल इंडिया रैंक। हाँ, ब्रह्मजोत कौर मैम, बिल्कुल ठीक कह रहे हो आप। तो अगर ये कर सकते हैं यार, और ये बहुत प्राउडली और एविडेंटली बोलते हैं कि प्राइवेट कॉलेज से पढ़ाई करी है ना। तो अगर ये कर सकते हैं तो आप भी कर सकते हो। मतलब मैं बोल रहा हूँ इतना मत फोड़ो तो कोई बात नहीं, मैं तो अगर दो जीरो हटा देता जीवन के अंदर तो भी खुश रहता। बट इंपॉर्टेंट क्या है कि आप अपने आप को ये देके बोल पाओ कि बॉस मैंने अपनी बेस्ट एफर्ट करी। यू जस्ट हैव टू बी वेरी कॉन्फिडेंट इन दिस पर्टिकुलर एस्पेक्ट। सी, ranks are going to be something which is a transient thing, right? Specialty is again something which is going to be heavily dependent upon a lot of multiple factors. But what you must always face with a lot of confidence is that I gave my best shot. For anything in your life, if you're not going to be having that confidence, you will always feel a feeling of regret. Regret, right? So if I forget, it's a small regret. If I forget, it's a small regret. If I don't get, it's a slightly bigger regret. But if there is a feeling of regret, it's very tough, severe. वापस आ रहा था डिस्कशन पे, वी आर गोइंग टू बी हैविंग अ डिस्कशन अबाउट सच मोर इंटरेस्टिंग एग्जांपल्स टू मोटिवेट यू. This is what we need to remember: beta thalassemia. So beta thalassemia is going to be associated with the patient who is going to be having the presence of a very severe kind of an anemia. So classically the question will say the patient is having a severe anemia and the value of hemoglobin in these patients is typically less than 7 gram per deciliter. Yeah, these patients are going to be having the development of the symptoms from an early age. So they are going to be requiring blood transfusion since early age. That's a very important hint. 2021's INICT question. Patients, parents are going to tell you about the fact. So the 10-year-old patient comes to you and he tells about the fact the child was requiring blood transfusions once or twice every week for their survival. So these blood transfusions start from an early age, typically around 6 months. Typically from 6 months of age, you can imagine. So this is an example of a very severe kind of an anemia that is called as beta thalassemia major. Then we are talking about something that is given the name of beta thalassemia intermedia. Beta thalassemia intermedia is the one in which patients are going to be having anemia which is in the range of 7 to 10. Hemoglobin is 7 to 10. But they require intermittent transfusions, off and on, not regular, off and on, off and on transfusion. And this is what we are also concerned with. The third one, which is given the name of beta thalassemia minor. So we understand it's an example of a minor kind of a trouble for the patient, minor kind of a trouble for the patient. But why is it important? Because these individuals do not know that they have a problem. They are asymptomatic. So they will come to you because their hemoglobin value is typically going to be around 10, typically more than 10, but it is not going to be exceeding 11, 11 or 11.5. So it is between 10, 10.1, 10.2, 10.4, 10.8, and it is not improving. It is not improving even when they are going to be taking iron supplementation. So thalassemia is a very important fact. It is diagnosed either incidentally, patient went for a healthcare policy, patient went for a PG, they did a screening and they found he was having a problem. And the second thing is that this is an example of an iron unresponsive anemia. So commonest cause of microcytic hypochromic anemia is iron deficiency. You give iron, patient is going to get better. But in case of thalassemia, if even if you give iron supplementation, patient is not going to improve. That's what you need to remember, right? And then there are certain geographical areas in which this type of a thalassemia is going to be more common. North, east, west, south. So north के अंदर पंजाबीज में ज्यादा कॉमन होता है. वेस्ट के अंदर गुजरातीज एंड सिंधीज आर हैविंग मोर ऑफ इट. ईस्टर्न साइड बंगालीज आर हैविंग इट मोर. सदर्न साइड वेरी कॉमन इन आंध्रा, तेलंगाना. right? Maharashtra, right? But that doesn't mean anybody coming from Punjab, anybody coming from Gujarat, anybody coming from Bengal is going to be having thalassemia, right? ऐसा नहीं है. But yes, it is prevalent, right? And it is more likely to, because of the fact it's an example of an autosomal recessive condition. More likely to be seen in case of families who are having closed marriages, consanguineous marriages, right? So that is again going to be important, right? So geographical areas and closed group marriages are going to be an important risk factor that we are going to be having the presence of thalassemia. So what are you going to be reading in the question in the exam? You're going to be reading the fact in the question, beta thalassemia major is going to be a major problem for the patient because hemoglobin is very severely closed, very severely less, and the patients are going to be requiring regular blood transfusion. Oh, now, why is it of a concern? The concern that you need to remember over here is that normally the hemoglobin is alpha to beta 2. If there is a beta thalassemia, beta chain is not available. So what will happen? Alpha chains are going to get precipitated. Alpha chains are going to get precipitated in the erythroblasts. And these erythroblasts will then not be able to survive properly. They will not be able to survive properly. So thalassemia is a problem in which there is ineffective erythropoiesis. RBCs during their stage of development in the bone marrow itself are going to die. As a result of which, what will happen? There is going to be severe anemia. And the body will try to compensate this anemia with the help of extramedullary hematopoiesis. Extramedullary erythropoiesis. This extramedullary erythropoiesis is going to be causing involvement of liver. It will cause involvement of spleen. It can cause involvement of different types of small bones. What is the normal area of hematopoiesis? Extramedullary hematopoiesis is going to take place. So liver is going to be enlarged in these patients because liver has to now produce blood, spleen has to produce blood, and bones in the body are going to be producing blood. So frontal bone is going to be becoming broadened. Maxilla and mandible are going to be affected. Patients are going to be having a depression of the nasal bridge. So all these are going to be responsible for having a finding in the patient. That is what is going to be observed by you. This is what is given the name of chipmunk facies. Chipmunk facies. Flattened nasal bridge. Frontal bones become prominent. Maxilla and mandible are also going to be becoming prominent because of extramedullary hematopoiesis. And the classical radiology question, when you see the skull bone being affected in the patient, when you see the X-ray of the skull of this patient, what are you going to be seeing? You are seeing the presence of a spiky appearance over here. This is what is going to be associated with the presence of hair on end appearance. So this appearance is what is going to be given the name of hair on end appearance. Hair on end appearance. No, Dr. Shizuka, I think you have to do. We have Shizuka, we have Doraemon, we have got Kinsun. नॉर्मल लोग वाले लोग भी है ना भाई, सारे कार्टून कैरेक्टर्स की पढ़ाई चल रही है आज, ऐसा तो नहीं हो सकता. So we are going to be having the presence of a patient who's going to be having the pediatric term. We are dealing with patients who are going to be having the presence of chipmunk facies. Hair on end is because of the expansion of the marrow cavities which are present between the cell, diploic spaces. हाँ हाँ नोबिता को भी बुला लो जाओ. Right? So this is what you need to remember about beta thalassemia. Right? This is what we need to be having an idea. So what exactly is going to be seen as a feature of this patient? What is going to be seen as a feature of this patient is going to be patients who are going to be having the presence of severe anemia, plus they are having spleen, liver being affected. That's what you see over here. Hepatomegaly, splenomegaly. Crooked appearance, hair on end. Hanji, same cheese, Dr. Bhavesh. Right? And you're also going to be having the presence of the peripheral smear finding like this. Now, you are going to be having the presence of microcytic hypochromic anemia over here. That is one important finding. Microcytic hypochromic anemia. अरे सुनियो, क्या तुमने देखा कि यहाँ पे आरबीसीज के अंदर यहाँ पे देखो देखो टारगेट सेल जैसी अपीयरेंस दिख रही है. So this is what you need to remember. So this is going to be the name of bullseye appearance. Bullseye appearance. Target cell appearance, target cell appearance और bullseye appearance. अब ध्यान रखना एग्जाम में गलती मत करना कि ये हीमोग्लोबिन के कारण है, ये मेम्ब्रेन प्रॉब्लम होती है सुनियो. जाओ शिजुका को भी बता दो. So anybody who wishes to go to an INI or wants to get a better rank in the exam, just remember this fact. It is going to be associated with not the hemoglobin. Hemoglobin is definitely going to be less. So there is going to be a paleness. There is going to be a paleness, that's for sure. But what is going to be seen over here is that there is a membrane defect. Membrane defect. So target cell is going to be seen because of a membrane problem. There is extra membrane relative to the hemoglobin. So that's your target. That's your target. Right? It's a membrane problem. Membrane is what is going to be causing the trouble in the patient rather than hemoglobin. It's not a hemoglobin problem. ठीक है, तो इसीलिए याद रहेगा एग्जाम के अंदर. We can see crooked appearance in sickle cell also, but it is going to be associated more importantly with something like thalassemia. ठीक है, so microcytic hypochromic anemia. So patient who's going to be a child, and listen to the 3 or 4 keywords carefully. Patient who's going to be a child, history of blood transfusion right from an early age, having the presence of severe anemia, chimpanzee-like faces, and having the presence of hepatosplenomegaly, and he's going to be having the presence of appearance of cells which are going to be associated with target cells. Target cells. Target cells are going to be produced because of membrane defect. There is extra membrane with respect to the hemoglobin. This membrane is going to be responsible for the formation of an appearance like this. Hanji. So the other name for the target cells, as he is rightly making a mention of, they're called as podocytes. आओ दोस्तों कोडों में बात करें. हाँ, कोड में बात करी हमने. So we talked about in codes podocytes. Podocytes. Coding करते करते Doraemon thalassemia, and that is going to be target cell. So our target is to crack the question in the exam, no matter howsoever we are going to be remembering it. Right? So this is what is going to be important. Now, if I want to make a diagnosis, see practical problem, what is going to be involved over here is going to be whenever you're going to be making a diagnosis of this kind of a condition. The investigation of choice that you must always remember over here is gene sequencing. Gene sequencing. Second thing which can be done for these patients is take their blood sample, go in for something like HPLC. Now, what is the problem with HPLC? The problem in case of HPLC is going to be the fact that a lot of these patients are going to be requiring blood transfusion. So suppose the patient came to you and he had a blood transfusion 24 hours earlier. He's coming to you on Wednesday, he had a blood transfusion on Tuesday. So he will be having his own RBCs as well as he's having the normal RBCs also. So you will never be able to detect the problem of the patient clearly. So it is better that if you're having a suspicion, if you suspect the patient to be having thalassemia, it is better to go in for something like a gene sequencing. And that's exactly what was asked to a INICT 2022 exams question. Patient was having anemia. He had a history of multiple blood transfusions. He came from the village to the city and you are suspecting thalassemia. So what is the best investigation that you would like to do in this patient? It is going to be something like gene sequencing. It is going to be something like gene sequencing. Right? Just pay attention to the fact if it is having a history of blood transfusions, multiple blood transfusions since an early age, it is beta thalassemia major. If the hemoglobin is having a value between 7 to 10 and there is intermittent transfusion, then that is going to be intermediate. But if there is going to be a beta thalassemia minor, then that is going to be typically asymptomatic and the patient is going to be having typically iron non-responsive anemia, which is going to be a mild kind of an anemia. Now, what is the importance of knowing about the beta thalassemia minor? The importance of knowing about beta thalassemia minor is going to be this important fact that all of you, hopefully by this point of time, do have an idea. Thalassemia minor. I can represent it for our sake of understanding as something like this. So there is a boy who has thalassemia minor. He loves a girl who also has thalassemia minor. They fall in love. And what is going to be happening is that there is a 25% chance 25% chance that they will have a baby who is going to be having thalassemia major. They have a baby who's going to be having thalassemia major. Now, these boy and girl were not at fault. भाई कॉलेज में गए हैं, प्यार तो करेंगे ही, वो अलग बात है कितने लोगों का प्यार पूरा होता है. But the fact that you need to remember over here is going to be that they were having no symptoms. They were having no symptoms. So they were not aware of this about thing. But as and when they got married and they obviously decided to extend their family, that's when they are going to be having this kind of a trouble. So we say that in medical terms, and it is being sensitized to a lot of people, especially in areas where the thalassemia is high, that it is for doctors and for as much as of the people as possible, that even if you do not match your kundalis for religious reasons or any reasons whatsoever, you must match your HPLC report. You must match your hemoglobin report. Because this is something which is going to be very bad. Taking a child to a hospital for a blood transfusion 2 or 3 times in a week, life is gone. It's a very, very bad situation. You feel sad for the patients. Unfortunately, you cannot do anything about it. Right? So this is what you need to remember about thalassemia minor, because this is clinically going to be asymptomatic. Now, how can we pick up this thalassemia minor? We pick up thalassemia minor, especially when we are talking about females who are expecting and who comes to institutional deliveries. Institutional deliveries, HPLC costs around 4,000, yeah, 3 to 4,000, depending upon the center as well. So you are going to be performing a screening test in them. This screening test is an osmotic fragility test, which is done with the help of a sample taken in a test tube. So this test is what is given the name of Nestrov test. Nestrov, as a lot of you may be familiar with the fact, is an example of a naked eye. From the naked eye, you don't need any sophisticated instrument for performing this test. Single tube. Take the blood sample of a patient in the single tube. Red cell osmotic fragility. ROF, red cell osmotic fragility test. If you take the blood sample of a normal individual and put it in saline, you will have hemolysis taking place. So you take the blood sample, and what you are going to be doing it over here is you put it behind. We are going to be having the presence of a cardboard paper having a black line. So in normal people, you are going to be having the visibility of the black line. Normal people, the black line is going to be visible over here very, very clearly. So this is going to be an example of a control. But in case of test sample, if your patient is having T for test sample, T for thalassemia, the black line is not visible. Black line is not visible. So especially when you get a hint in the question in the exam that the patient was having microcytic hypochromic anemia, it was not responding to iron therapy, and in the screening test, the black line was not visible. You think in terms of the patient could be a patient having thalassemia. So what do you have to do in for next test? This is a screening. Nestrov test is a screening test. You have to do the confirmatory investigation. Confirmatory investigation is going to be gene sequencing. If not given as an option in the exam, of course, the next best thing that you have to go in for over is hemoglobin HPLC. Hemoglobin HPLC. पेशेंट हैविंग हेरिडिटरी सिरोसाइटोसिस में तो ज्यादा जल्दी हिमोलाइसिस हो ही जाएगा ना, उसमें हम स्क्रीनिंग टेस्ट वैसे ही कर लेते हैं. Podocyte is simply this cell. Podocyte is just an example of a target cell. RBCs which are going to be having an appearance like this. Bullseye appearance because of extramembrane. Normally, the black line is visible. Remember it this way. Black line is visible in case of normal people, you and me. Right? But in case of thalassemia, the black line is not visible. Nestrov test is not going to be required for thalassemia major na yaar. Thalassemia major में तो anemia so severe, the child cannot survive without blood transfusion. वो तो वैसे ही पता चल जाता है हमें on the basis of during the 6th month. So in case of thalassemia, why is this taking place? For the simple fact, in case of thalassemia, the red cells have decreased osmotic fragility. In thalassemia, red cells have decreased osmotic fragility. Osmotic fragility is less than them. हाँ Kshitij, very good. Black is beautiful. Black is beautiful. No black, trouble. Investigate the patient further. You can diagnose it with the help of something like gene sequencing or maybe something like hemoglobin HPLC. Okay? That's what you need to remember over here. Now, please remember the fact in case you are asked a question in the exam. Thalassemia minor, thalassemia major. Which type of hemoglobin is useful for picking up these conditions? In case of thalassemia minor, we are looking at the concentration of HbA2. In case of thalassemia major, we are looking at the concentration of fetal hemoglobin. So when the value of HbA2 is more than 3.5 gram per deciliter, this is a patient that we are dealing with thalassemia minor. In normal people, the value of HbA2 is typically less than 3. But when the value of HbA2 is more than 3.5, it is diagnostic of thalassemia minor. What is the normal percentage of HbF in you and me? In case of you and me, the percentage of HbF is around 1%. But in case of patients who are going to be having thalassemia major, the percentage of HbF is going to be more than 90%. More than 90%. Normal people less than 1. In these patients having thalassemia major, it is going to be more than 90. So please remember the fact that there are different hemoglobins which are useful for detection of different types of thalassemias. Thalassemia major with HbF, thalassemia minor with the help of HbA2. This is an example of a screening test. The other thing is what we talked about already. Patients who are going to be having the presence of microcytic hypochromic anemia can sometimes be confused with a common condition that is iron deficiency anemia. So for differentiating them, we are going to be doing a test, and that test is Mentzer index. MCV divided by RBC. I for increased value is more than 13. Thalassemia, less emia, less blood. Value is less than 13. Yeah, so that is what you need to remember. Of course, practically speaking, IDA will be responding to iron therapy. Thalassemia is not going to be responding to iron therapy. Right. So this is what we just need to have an idea so far as the concept of beta thalassemia is concerned. हाँ जी बिल्कुल थल्ले थल्ले लग गया बिल्कुल ठीक कह रहे हैं हीमोग्लोबिन भी थल्ले लग गया मरीज भी थल्ले लग जाते हैं 3 बार खून चढ़ाना आसान काम नहीं है then we are talking about something called as alpha thalassemia less likely to be asked in the exam but then you need to have an idea. This is a genetic defect. It's a specific genetic defect that is going to be seen in the patient. IVS is a problem intervening sequence IVS ब्रेक क्या करोगे लेके यार ब्रेक ही तो चल रहा है अल्फा थैलासीमिया अल्फा को अगर आप लिखोगे तो ऐसा लगेगा अल्फा अल्फा लुक्स लाइक जस्ट लाइक अ क्रॉस है ना क्रॉस क्रॉस मार दिया गलत है ये इसका मतलब है दैट दिस इज गोइंग टू बी एसोसिएटेड विद नो जीन फॉर्मेशन so this is going to be caused because of gene deletion this is going to be seen because of gene deletion right so we are going to be having different situations which can be seen in the patients and these are the 4 conditions. Condition number 1 for 2 genes you require 4 genes कोई बात नहीं यार वो हमारे ही दोस्त हैं हम ऐसा नहीं है कि हम संतों से आए हैं जो पेशेंट्स होते हैं इनको हाइपरटेंशन होती है डायबिटीज होते हैं जो स्मोक करते हैं ड्रिंक करते हैं हमारी ही सोसाइटी का पार्ट है हम भी सोसाइटी का पार्ट है तो हमें एक्सेप्ट करना पड़ेगा ना ऐसा क्या होगा कि हम बोल रहे हैं कि अच्छा अरे सर वो ब्रेक होती है ना वॉशरूम चला जाता है वो पानी पीने चला जाता है वो सुट्टा मार लेता है भाई कोई बात नहीं हम समझा सकते हैं हम अपने आप को कर सकते हैं स्ट्रेस में आ गया भाई कम करिए तेरी सेहत के लिए ठीक नहीं है तुम नॉन एक्सेप्टेबिलिटी लेके आओगे तो फिर तो तुम पिताजी वाले मोड में आ जाओगे ना कर रहा है तो कर लेंगे भाई टेम्परेरी कर रहा है ना हम उसकी काउंसलिंग ऐसे करेंगे एक्सेप्ट तो करेंगे उसे अगर तो बोलेगा हमारे जैसा ही नहीं है फिर तो वो वाली बात हो गई ना कि पेशेंट्स आ गए तुम्हारे पास द पेशेंट इज हैविंग एड्स और तुम उसके चप्पल घुसे लात मार रहे हो कि बेटा मजे लेके आया और हमारी जान निकाल रहा है ऐसे थोड़ी ना करते हो कभी तुम यू आर गोइंग टू बी सिंपैथेटिक टू द पेशेंट ना कि जो भी किया भाई कोई बात नहीं बट वी आर नाउ गोइंग टू बी टॉकिंग टू यू मोर पोलाइटली विल टेक केयर ऑफ योर ट्रबल्स ठीक है सो साइलेंट कैरियर इज इफ वन और टू जीन्स आर डिलीटेड इफ वन और टू जीन्स आर डिलीटेड then that is going to be given the name of a patient being asymptomatic. But when the patient is going to be having deletion of 3 genes, this is what you need to pay attention to. When 3 genes are going to be deleted, that means the alpha chains are produced very less. यार तुम करवा देना मेरा मीम पेज शुरू तुम एग्जाम क्रैक कर लो उसके बाद ये सब करा लेना right? So three alpha chains, three genes are deleted. So alpha chains are very less, 25% only. So what is going to be happening? The beta is going to be having a formation of tetramer. दो लड़के दो लड़कियां जोड़ी बन जाएगी. अब कन्याएं कम हो गई तो लड़के आपस में दोस्ती कर लेंगे. कन्याएं बहुत ही कम हो गई तो लड़के आपस में प्रेम भी कर लेंगे. HBH. Beta is alpha is not there, so beta is going to be having formation of tetramer amongst themselves. But that is going to be something which is going to be causing a trouble to the patient. Why? Because we are going to be having formation of an abnormal hemoglobin. So normal hemoglobin is alpha 2 beta 2. But when there is going to be formation of tetramer of beta, this is going to be HBH. And what is the problem with HBH? HBH is going to love oxygen very, very strongly. It will not give oxygen to the tissues. If it is not going to give oxygen to the tissues, there is going to be a development of hypoxia. Hypoxia. Right? So that is what you need to remember. Then we are going to be having a situation in which HBH is going to be seen that can be picked up with the help of new methylene blue. So RBCs which are going to be having HBH are going to be having an appearance which is given the name of golf ball appearance. Golf ball appearance. What is the fetal hemoglobin? In the developing fetus, what is the HbF made up of? HbF is made up of alpha 2 and gamma 2. HbF की बात हो रही है भाई. Alpha 2, gamma 2. Right? If there is going to be a fetus in which no alpha chain is being produced, all the four alpha chains are deleted. So there is going to be formation of gamma 4 tetramer. Gamma 4 tetramer is what is going to be given the name of Bart's hemoglobin. So these used to be one-liner questions that you just need to have an idea. One-liner questions about which you need to have an idea. HbH is beta 4, but Bart's hemoglobin is gamma 4. And the problem with gamma 4 is that this baby is very minimally going to be having a chance of survival. So it is lethal in utero. With transfusions, obviously it can be made to survive with a force, but most of the times hydros fetalis is what is going to take place. Now, what is the importance? You read about hydros fetalis also in case of another condition. You read about hydros fetalis in case of RH incompatibility, right? But in RH incompatibility, there is an antibody produced against the RBCs because of which hydros fetalis takes place. In this condition, there is no antibody. So alpha thalassemia, please remember, is a very important reason for development of non-immune hydrops fetalis. Non-immune hydrops fetalis. It's a very important reason for development of non-immune hydrops fetalis. That is what we need to keep in mind. So relatively lesser chance of alpha thalassemia being asked in an exam, but we have to be prepared for the exam in any which way. So when one gene or two genes are deleted, remember, don't forget this fact, gene deletion is causing the trouble over here. Then it is going to be asymptomatic. But when three genes are going to be deleted, it is going to be responsible for causing development of a disease called as HbH disease. When all the four genes are deleted, it is going to be associated with formation of Bart's hemoglobin. And Bart's hemoglobin is going to be associated with development of non-immune hydrops fetalis. It is lethal in utero. What can be the questions asked in the exam? From beta thalassemia, appearance of the patient, podocytes, target cells, microcytic hypochromic anemia, presence of hepatosplenomegaly over here, and the patient going to be having the presence of extramedullary hematopoiesis and having the presence of chimpanzee-like faces. Best diagnosed confirmed with the help of gene sequencing. So far as the screening test for thalassemia minor is concerned, that is a Nestrov test, and differentiation between IDA and thalassemia trait done with the help of Mendzer index. Which hemoglobins are you going to be using for thalassemia minor? HbA2, value more than 3.5. Which hemoglobin will you use for thalassemia major? HbF. When I'm talking about alpha thalassemia, you have to remember about HbH inclusions. These are the example of the golf ball inclusions. Golf ball inclusions. Right? And they are suggestive of patient having alpha thalassemia. How many chains are deleted? How many chains are deleted? Three. Three chains are going to be deleted over here. ठीक है, ये वाली चीज हमें ध्यान रखनी है. यस, ब्लू कलर का स्टेन आ गया ना, तो आप आइडेंटिफाई कर ही लोगे अब तो यार, ये न्यू मिथिलीन ब्लू है. दिस इज गोइंग टू बी एन एग्जांपल ऑफ अ न्यू मिथिलीन ब्लू. This is going to be an example of a new methylene blue. That is what we need to remember. ठीक है, ब्रेक चाहिए अभी? छोटा सा ब्रेक ले लो, वाटर ब्रेक, लू ब्रेक, वट एवर ब्रेक यू विश टू गिव इट अ नेम ऑफ। हाँ, 5 मिनट का ले लो यार। लेट्स हैव अ शॉर्ट ब्रेक एंड देन वी रिज्यूम। पढ़ना है यार, पढ़ना इसलिए थोड़ा पढ़ना है कि तुम्हारे नोट्स के अंदर लिखा हुआ है तुम टिक लगाए जा रहे हो, मेरे नोट्स के अंदर लिखा हुआ है मैं टिक लगाए जा रहा हूँ। पढ़ना है इसलिए बिकॉज दिमाग के अंदर जाना चाहिए। ठीक है, तो 5 मिनट का ब्रेक यार, जल्दी से जिसको जो भी काम है, आवश्यक काम है। किसी के ब्लड सेल्स पानी मांग रहे हैं, किसी के फेफड़े ऑक्सीजन मांग रहे हैं, किसी के फेफड़े कुछ और मांग रहे हैं, जो मांग रहे हैं जल्दी दो, वापस आ जाओ।